Welcome, everyone. We're going to go ahead and get started since it is 1 Eastern by my clock. Hello, and thank you all for joining today. It is my pleasure to welcome you to this PQI Innovation webinar titled Lessons Learned from a Statewide Learning Collaborative to Improve Severe Hypertension Recognition and Response. My name is Kaylee Vitek, and I will be operating the Zoom logistics of this webinar and introducing today's speakers. When I'm not providing tech support for PQI, I'm a project manager for the Massachusetts State Perinatal Quality Collaborative. So I'm excited to see some familiar names. A couple of housekeeping items before we meet our speakers. This webinar is being recorded and will be posted for free on the PQI website. There will be time for Q&A at the end of the presentation, so please type any questions you have into the chat and we will address them during that Q&A portion. If you experience any technical issues, please send me a private message and I will do my best to help. Now to introduce our speakers. First, we have Emma Trucks, MPH, who has over 12 years of experience working in healthcare quality improvement as a manager, advisor, and educator. Ms. Trucks is a high-performing manager of programs, projects, and people, and is an experienced consultant addressing gaps in clinical quality and performance. Ms. Trucks has run multiple large and small-scale learning systems in several states on a variety of clinical or quality topics. Her experience includes coaching clinical and non-clinical staff on how to interpret performance data and leverage evidence-based strategies for improvement. Next, we have Christina Southey, Master of Science, who is an improvement advisor and facilitator who supports improvement projects in the United States and Canada. She has supported numerous breakthrough series collaboratives across multiple topics, and she teaches improvement skills to professionals in small and large group settings in North America and internationally. And last, but certainly not least, we have Dak Ojuka, BS, who is a consultant within PCG's Health Policy and Program Evaluation team and is an experienced integrator of the policy and data elements of Medicaid redesign initiatives, with an emphasis on promoting health equity and addressing social determinants of health. Having earned a dual degree in biology and business studies from Providence College, Dak is proficient in conducting comprehensive health policy research and analysis at the state level. And now I'll turn it over to Dr. Deborah Bingham, who is the founder and CEO of the Institute for Perinatal Quality Improvement. Thank you all for listening, and we hope you enjoyed the webinar.
We're so grateful to have you here, and I think you'll all be grateful that you came because we have such esteemed colleagues who are presenting today. So I'm going to just give a quick update on some of the cool things happening at PQI. And so just to let you know, why we exist is unfortunately not such great news, is the high rates of infant mortality and this variation across the United States and across counties within the different states. We also have seen a rise in pregnancy-related mortality deaths, and 80% of these deaths are preventable. So both of these issues are a huge reason for our existence. And we are working to also eliminate disparities that are both sustained or are still significant for infant mortality, as well as for maternal mortality and pregnancy-related mortality. In fact, this graph shows how that the non-Hispanic Native Hawaiian or Pacific Islander, non-Hispanic Black, and non-Hispanic American Indian or Alaska Native have much higher proportion of maternal pregnancy-related deaths than white and white people and the non-Hispanic Asian and Hispanic. We also are concerned not only with the high rates of mortality, but also with the high rates of morbidity, both infant and pregnancy-related morbidity. And this graph shows that we have seen a rise in severe maternal morbidity in the last several years. And it's a very concerning trend that we have happening. So the Institute for Perinatal Quality Improvement, as I just said, was formed to address these high rates, and the mission for PQI This mission is how we make all of our decisions. Everything we do is, we ask the question, does this meet our mission or not? And our mission is to expand the use of improvement science to eliminate preventable perinatal morbidity and mortality and perinatal racial and ethnic disparities. With that, we launched the Speak Up program back in 2018. This program has a vision that all perinatal health professionals will be Speak Up champions, and with a long-term goal that the Speak Up champions will be working with us to eliminate these racial and ethnic disparities and ensure that the inequities in healthcare that cause these disparities are also eliminated. We have the acronym and mnemonic, and Kaylee just put that in the chat. So if you're not familiar with the Speak Up acronym or mnemonic, you can access that from our website. We have held a lot of national conferences. We have more scheduled. We've led several statewide conferences. So we now, this map shows where our different Speak Up champions are from. And it's not a one and done. Anyone who's done the Speak Up Champion training or courses know that it's a whole pathway. So this is our pathway showing steps 1, 2, and 3 are the Speak Up Champion activities. They even have little check boxes we want every champion to have accomplished. And then once you become a champion, we're hoping people go on to further their knowledge by becoming ambassador, and then a select few of ambassadors can be selected to be faculty. And it is team taught with both a person of color and a white person teaching the course. And we do currently have some new additional national faculty working with us. And we are going to be hosting a new faculty course this fall. So feel free to look at the requirements for becoming faculty and consider applying. You need to be an ambassador before you can, you need to be a champion before you can become an ambassador. We have had other national courses. So I know that in this case, our champion course is after this particular ambassador course, but we will be hosting more ambassador courses in the future. And the live virtual component is how most of these courses occur. And 8 hours to undo over 300 years of slavery and racist codes is really not a very big commitment. And actually, it is just the very beginning. So then the ambassador course helps dig even deeper. And then then the ongoing work of individuals is also really critical. As part of that, then we also include these online modules that will help further people's education and also serve as support reminders and support for those who are completing the virtual live sessions. We now, as QI people, have also look at what we are doing, is it good enough, or do we need to change our program? And we now have several years of data showing us, and this is our evaluation framework for our Speak Up program, which starts with knowledge, awareness, attitudes, changes in behaviors, ultimately getting to equity. And I am very excited to share with you, we will have a poster at A1 Convention in June, and yay. Oh, so Tracy, hopefully I'll see you there, and others. And I will tell you, just give you a little highlight. I know this slide is way too busy for me to give you all of the details, but just want to just point out that this knowledge, awareness, attitudes, and shift in behaviors, you can see between our pre-survey, our post-survey, and our implementation survey, that the results are very impressive. We are pleased to say, and that we are making huge shifts for a lot of people who take our classes. So for example, this situation of I regularly hear and see situations where Black and/or Indigenous individuals are treated with disrespect or worse shifted from 56.4% to 98.1% between the pre and post survey. and just also attitudes around the reality that racial categories were created and accepted by society to label people for economic or political gain, went from 70%, 70.4% strongly or agreeing to 91.1%. So that's huge. And we're thrilled that we also have some data to show that people who responded to our implementation survey, although the N is low, those 48 people are making behavior changes both in their personal lives and in their professional lives. And that was really a huge, that's what we ultimately want to get to. So if you haven't joined us yet, we hope you do our next national course. And then we also do run state courses. We also have just launched, and we just did a whole lottery. We had over 350 people who applied to receive free access to the birth equity modules. These are 4 modules that go over 4 different important topics. And so it's an entire course. And we were able to get at least 2 people from every state that had people apply. We went ahead and randomly selected them, and they are currently accessing the course. And then it will be publicly launched on May 22nd. We are going to be doing a national webinar just about the module and giving you a preview of what's in that module, in those modules within that course. So hopefully you join us. That registration is live and it's a free event. The IA, the intermittent auscultation, it's one of my big priorities for this year, is to have more people use IA. I think it's an essential skill for low risk pregnancies, which are should be about 80% of your population in general. So if you haven't accessed this or you're interested, feel free to do so. And also we will be releasing version 3 in May. So don't access, I would just say wait to get version 3, because there are some shifts and some changes we made between version 2 and 3. We've had 3,379 learners with the IA course, and very strong positive feedback on the importance of this course. So we'll see many of you at the A1 convention. Please also we'll be doing that presentation on intermittent auscultation at that course. At that convention. We also will be showing our Speak Up poster at convention. And then also just love to, I'm constantly looking for people that we can do PQI profiles on, also present webinars. So I'm just excited to hear about all the great work you all are doing and how we can all help each other make improvements in the United States. So feel free to reach out to us and let us know if you have any questions or suggestions. Without further ado, and I know I just went through a whole bunch of information very quickly, but we want to make sure we have plenty of time for our amazing speakers. So I'm going to now turn it over to Emma Trucks and the rest of the presenter team. So thank you, Emma.
Thanks, Deborah. And you can go to the next slide. And I'm excited for us to share our story about how we got 37 competing healthcare organizations to work together to accelerate improvements with a state-identified population health priority, specifically to improve severe hypertension recognition and response with timely treatment. Next slide. And as we get started, I think at the end of our talk today, we have several objectives in mind, and we hope you can recognize the value in using a continuous quality improvement process to implement the AIM Severe Hypertension Bundle, or really any bundle. I think we found many of our participating teams had already, rolled out the bundle. But when you don't have that continuous quality improvement process, it might be a policy collecting dust in a binder somewhere. So definitely recognizing the value there. To see the value in using the evidence-based breakthrough series collaborative model to accelerate improvements across a health network, provider network, state network, to recognize the value in directing state funding to help overcome challenges with active participation in quality improvement efforts or public health priorities, and to recognize the importance of integrating or really centering equity into any quality initiatives. And lastly, we hope you'll learn a few successful strategies to improving the timely treatment of severe hypertension. And some of the things we'll highlight in today's call, because there's too much to share in the call to tell you everything. But we'll focus on a few things that maybe go above and beyond the AIM bundle that were unique to our program. Next slide. I do want to acknowledge the Maternal Learning Collaborative team, our amazing team. So first of all, I'll just acknowledge and thank the New Jersey Department of Health, who engaged Public Consulting Group, our team from PCG, to support their Quality Improvement Program New Jersey, which I'll explain in a moment. And from that program, we were able to run the Maternal Learning Collaborative through their commitment and investment in this evidence-based model. My name is Emma Trucks. I served as the collaborative director, and my colleagues Dak Ojuka, the collaborative coordinator, and Christina Suthy are presenting with me today. But of course, I have to acknowledge the rest of our team, Deborah Bingham, who you're all familiar with, our lead clinical faculty, Grace Ann Frederick and Grace Mecha, who are also collaborative coordinators, and Dr. Ron Iverson from Boston Medical Center, who served as our physician clinical faculty. Next slide. Turn it to Dak.
All right. Good afternoon, everybody. I'm so excited to be here with you, especially during such an important month in the women's health space. So this starting slide here provides the framework for why we had this collaborative. So as Emma said, the state of New Jersey identified that there was an opportunity to improve maternal health outcomes across the state. So the first graph here compares New Jersey and the national pregnancy associated deaths in 2017 and 18. Note pregnancy associated deaths kind of make up the entire spectrum of maternal mortality, right? So a death within 1 year of pregnancy, regardless of the cause. And then on the right, we switch over to severe maternal morbidity, specifically in New Jersey, stratified by race and ethnicity between 2011 and 2019. And I think the overall message here is that the data shows that historically, Black women have experienced worse outcomes compared to all women. So in 2019, the state ranked 47th nationwide because of its high rate of pregnancy-related deaths of the mother. But in its 2023 report, America's Health Rankings actually found New Jersey overall had jumped to 27th nationwide for maternal mortality. So that's a great improvement. You can go to the next slide. So our collaborative is just a piece of a broader context. There's a lot going on in New Jersey to improve maternal care amongst multiple different organizations and initiatives. And our Maternal Learning Collaborative was one of them. A very useful resource for us was the MMRC, or the Maternal Mortality Review Committee, which had up-to-date data for us to review. So on this slide, we can see a level deeper when we get into pregnancy-related deaths, right? So which is a death within 1 year from a pregnancy-related complication. So we can see that the numbers get even more harrowing because more than 80% of the top 4 pregnancy-related underlying causes of death were determined to be preventable. So we can see that hypertensive issues are one of the most persistent causes of severe maternal mortality. And the data shows that all deaths due to hypertensive pregnancy disorders between 2016 and 2018 were preventable in New Jersey. So the MMRC then provided recommendations to prevent hypertensive death, and they said providers should utilize the AIM bundle on severe hypertension in pregnancy, as well as monitor for pregnancy-induced hypertension signs and symptoms. And so that's what we did. So you can go to the next slide. And I just want us to take a second to reflect on the fact that the data can never capture the value of just saving one life, right? Because it has an impact that cannot be measured for the child, for the family, or for the community that's surrounding that mother. So I'll turn it back over to Emma.
Thanks, Dak. Next slide, please. So the collaborative was not taking place in a vacuum. There is a ton of amazing work happening across New Jersey from a local level up to a state level that were happening at the same time as our efforts. Of course, New Jersey, the First Lady of New Jersey has established a strategic plan to make New Jersey the safest place in the nation to give birth and raise a baby. And that's put a great central focus on this issue, and I think has helped with a lot of the action you see outlined on this slide. And this is just a sample. For example, New Jersey has the Universal Home Visiting Program established now. New Jersey was the third state in the nation to provide Medicaid coverage for doula services, and some amazing improvements in reimbursement parity, with Medicaid reimbursement rates for physicians and midwives to match 100% of current Medicare rates, and having all midwives receive the same reimbursement rate as physicians for all covered services. So this is just a little sample of all the great things going on while we were doing our collaborative. If you go to the next slide. So the Quality Improvement Program, New Jersey, was a Department of Health sponsored, is a Department of Health sponsored Medicaid managed care pay for performance program. And so what this means, it's a small segment of the overall state-directed Medicaid funding for acute care hospitals. And the funds are targeting improvements through performance-based measures for targeting the behavioral health population and the maternal health population. So 30% of the funds are earmarked for maternal health. And the portfolio of measures to improve maternal health really focus on measures that show improvements in maternal care processes and reductions in maternal morbidity. And one of those measures is the improving the timely treatment of severe hypertension. And with the help of different state-based stakeholders and community stakeholders, we identified that particular measure as an opportunity to form the Maternal Learning Collaborative and accelerate improvements in that area. Next slide. And so the aim that we developed for the program by December, so it was actually a 14-month program. So over the course of a 14-month collaborative that ended this past December, the goal was to improve by 15% the rate of severe hypertension episodes treated with a first-line agent within 30 to 60 minutes among women and birthing people who were receiving care at New Jersey Acute Care Hospital, inpatient maternity, and emergency department units. And a focus of the initiative was to eliminate inequities for Black women and birthing people in New Jersey. Next slide. And I'll turn it over to Christina.
Thanks, Emma. So many of you may be familiar with the iTRI's Breakthrough Series collaborative model. And the Breakthrough Series collaborative model is a tried and true methodology to bring groups of teams together who are all focused on the same topic and be able to move them through a series of group learning events and action periods focused on testing and implemented high leverage changes that we know work to be able to bridge the gap between where we are and where we could be. And so given the strength of this methodology, this was the model that we chose to leverage when looking at the collaborative project within New Jersey. And in alignment with that, if you go to the next slide, like many collaboratives, what we built as part of this work were some of the traditional resources that are critical to the ability for teams to be able to identify the changes that they might want to test and then track their progress with those changes over time. So you see on your screen the key driver diagram and change package, which I'll go into in just a moment, the measurement strategy, and then something which we put a lot of effort into, and really kudos to Dak, because without him, we couldn't have done all the measurement work that we did. But really going beyond just creating a measurement strategy and really ensuring that we had the resources for teams that we needed around understanding the data collection process and had really high quality visuals that teams could use to be able to input their data and use that data for quality improvement, despite what their on the ground resources were. So they were able to leverage that through the resources and the resources that were built by Dak and by the PCG team. So if you go to the next slide, Just wanted to stop for a minute and talk about our driver diagram, because this is something that for many of you that are already familiar with the AIM bundle on severe hypertension, as Emma was mentioning, we use that as a foundational document in building the change package for the collaborative. So you'll recognize at a glance some of the key focus areas, the primary drivers that you see in this document. But what we did on top of that AIM bundle was we consulted with a number of experts in New Jersey, as well as external to New Jersey, to look at what additional components should we be highlighting in there? What are some specific change ideas that we can pull directly from things that are already being tested within the area to give people more concrete ideas and give them some potentially other considerations that they might want to look at or should be looking at within their systems. And through that, we added more focus on equity, and again, pulled from the AIM bundle on equity to make sure that that was integrated into the work that we're doing, especially given the dual focus in the AIM on not only improving the timeliness of care, but also reducing the disparity of care. And then also making sure that we had a large focus on the inclusion of people with lived experience and patient experience as a critical component of how the work moved forward. And then the next slide, the other component that's critical in being able to set us up for success and in being able to know what the progress was that we were making in this work was the learning collaborative measures. And so again, we tried where we could to be able to align with measures that we knew were out there, not only in alignment with measures that existed in New Jersey that were being used. So for instance, our timeliness of treatment measure, we tried as hard as we could to be able to align with requirements that already existed in terms of definitions. But then we also looked at what existed in AIM around recommended measures and brought those in as much as we could. But on top of that, in consultation with the experts, including Deborah Bingham, we really explored additional measures that were seen to be critical for teams to look at some of the broader concepts beyond just the treatment with that first line agent. So you'll see in there, to call out a couple, that second measure on timeliness of triage, that was put in to be able to capture strong encouragement from Deborah Bingham and being able to capture that time from when someone presents at potentially the ED most often to when they actually get that first blood pressure taken, as that was sort of like an invisible lag because it wasn't necessarily being captured in that timeliness of treatment metric. So that was one that also we knew that every single hospital could look at, even if they only had a very small amount of births in a month or in a year, they could still look at that first blood pressure taken from presentation at the ED or presentation at the OB unit because it was well within their control. The other two that came up, the other three, postpartum follow-up, meds on discharge, and home BP cuffs. So the postpartum follow-up, looking at shrinking that time of accountability down to 72 hours upon recommendations from the experts. And then really the meds on discharge and the home BP cuff, those were seen as high leverage change ideas from our expert faculty that were things that hospitals could set up in terms of programs or supports for people postpartum and upon discharge that would significantly impact or reduce the chances of complications after birth. And so those were two areas that we encouraged teams to track. They weren't tracking when they started the collaborative. I don't think any of our teams initially had that on their purview of measures, but were helpful in being able to put that as a priority for folks as they move forward. And with that, the next slide, and I'll hand it back over to Emma.
Thank you. All right, so you kind of have a sense of the problem we were trying to solve in the context of our program and the method. So we'll talk a little bit now about lessons learned and some of our results. So we can go to the next slide. So just looking at our program as a whole, like what happened in the collaborative, who was there? We had 37 actively engaged participating teams, and 35 of those teams were able to begin submitting data every month on at least one measure, but in most cases, more than one. We hosted 3 virtual learning sessions, which took the form of like 3-hour virtual calls. And then we also hosted 11 group coaching calls, which were on a monthly cadence, intervening between the learning sessions for those supporting those action periods where people were testing changes. And those were in the form of just 1-hour virtual webinars. We had, across our teams, we had 104 teams, 104 storyboards submitted by teams, which they presented at our 3 learning sessions. And we had a total of 319 monthly data submissions over all months of the program, which on average was about 9 months of data submission for each team. So we were really just thrilled and excited by that level of engagement around the data. And we had 263 individual participants representing the different teams that we had. We had a fantastic group of really dedicated interprofessionals, an interprofessional group of dedicated healthcare staff, and we really appreciated the effort that they put in. Next slide. So for just digging into some of that engagement and some of the strategies we think led to our success right off the bat, is first of all, we put a ton of work into pre-work and getting teams prepared and onboarded. The BTS model, provides guidance on creating a pre-work handbook or a pre-work package, and we did that. It included guidance on how to form the most effective interprofessional team with FTE estimations to really help make sound decisions on how to practically make it work. We provided sample agendas for the first few kickoff meetings, and it included things like guiding questions to interview staff and patients to get baseline experience data, as well as system reviews to understand your current state. So we really had a thorough package. We hosted information sessions to build buzz and clarify expectations. And in addition to that, we hosted a pre-work webinar to dig into each of these elements and make sure teams were the most prepared and we could have the most effective experience sharing learnings at learning session 1. We did offer one-on-one coaching, which we noticed was used more so in the beginning and the onboarding process and not so much as the collaborative progressed. About halfway through the program, we performed an in-depth midpoint assessment. So we just tried to see, we made some definitions for what active engagement was. We identified struggling teams based on performance or their capabilities around data collection. And we used that moment to sort of provide and additional support to kind of get our struggling teams on the same path of momentum as their colleagues. And it also helped us celebrate early wins and identify teams to spotlight their successes. Of course, the state funds through the QUIP NJ program focused on maternal health definitely helped overcome some barriers around leadership support for designating the staff time, and just allowing teams to be formed and to participate. I think a really, really important piece is that we made an effort to engage people with lived experience as speakers and faculty, and that started during the information sessions and continued through all of the learning collaboratives, the learning sessions throughout the collaborative. And then in general, the benefit of a continuous quality improvement effort is that as a planner, you should be adaptable in the moment. So looking at the data, listening to what teams were experiencing, we were able to recruit speakers, both external as well as right from our own pool of participating teams, to present solutions to challenges that were happening in real time. So that adaptability, I think we kept people's focus because we were meeting their needs in real time. Next slide.
Great. So I'll just hop in. So just getting a little bit into our measurement strategy development, I will first start by saying we were really satisfied with the momentum of data collection within this collaborative, especially considering that timely treatment is a very manual process of data collection. I'll also note that, again, timely treatment of severe hypertension was a chart-based paper performance measure in our QUIP program, which was a great motivator for our team since they were having to manually abstract this data annually within the program. So our challenge and our goal was to get them to do this on a monthly basis to support real-time QI efforts. And they did. So what this slide is meant to show is your measurement strategy and your data collection strategy is a two-step process that sort of happens simultaneously as you're recruiting and doing the pre-work and understanding where your stakeholders are in terms of resources and capabilities. So altogether, it took us about 3 months to develop both. And early on, we made eliminating inequities a clear priority to our teams, and it was built into our design from day one. And yeah, again, with the data collection process, just make sure quality over quantity, right? And all teams won't be able to report on all measures. That's okay. Just meet teams where they're at. Can go to the next slide. So this just shows, so we created a monthly data collection survey through Jotform. Then teams would insert their monthly data into the tool. We would do data validation and cleaning to be able to create monthly visualization reports, which we would then provide back to teams to review, compare, contrast their identified performance against the aggregate. So just a few recommendations. You want to try and keep the workflows as simple as possible, especially for your stakeholders. You can see they only have 2 steps here. You want to de-identify the data when you can. This makes teams more comfortable with submitting their data. There's also always potential for human error, especially with manual extraction. So you want to try and be sure to implement as many validations as possible into the survey itself to save time for you in the kind of the data collection or the data analysis process. And again, while the ideal scenario is to observe consistent data reporting by the same individuals each month, this is not always the case, right? So the goal is to help teams start reporting data as soon as possible on a small scale that accommodates their abilities, which can be built up over time. You can go to the next slide. Finally, I know this is a text-heavy slide, but just stay with me. You really want to prioritize the patient experience to identify inequities, right? Because we knew that for some teams, there was no discernible trend in the 12 months of data that we collected to be able to say whether there was actually racial disparity in their data or not, right? Statistically speaking. But we know that these disparities do exist using state level data, right? So quantitative data sometimes isn't enough. So we had to find other ways to express this, which started through the pre-work and continued by working with groups like Mama's Voices, who was able to bring in people with lived experience to speak to our teams and learning sessions. And this really helped teams to sort of understand where and how these disparities exist. So what can we do? We may not be able to get a white paper out of it, but we can use patient experience data to identify trends from patients themselves. So we had a maternal experience tab in our dashboard and even worked to partner with the NAACP maternal experience survey. Though it lost funding around the midpoint of our collaborative, that patient experience data had over 200 respondents and showed inequity of experience for Black women in New Jersey. Specifically that they were less likely to bring up a concern to their medical team or with their healthcare provider after delivery. And in general, only about 50% of all patients asked their medical team for help when they were reported actually experiencing a complication. So these were very stark and impactful New Jersey specific data points that reflected the opportunity to improve the patient experience and trust within maternal care, recognizing warning signs and seeking medical help in relation to those hypertensive emergencies. So there's just here some stats on our data collection success. Most teams had not been stratifying these manually abstracted measures before this collaborative. So you can see some of the stats there. And on the bottom right, Emma will speak a little bit more to the common data challenges. So I can skip over that for now. I think that's the next slide. So this slide here just shows on the left some sample interview questions for patients, support people, and staff from our pre-work handbook to help guide conversations and engagement. And on the right is a screenshot of our actual Tableau dashboard that had 6 different tabs for teams to interact with that ranged from aggregate totals to individual performance. But yeah, I will now pass it back over to Emma.
Thanks, Dak. And I can just add, the dashboard was something that evolved. Dak was able to design new tabs as as more teams started to submit data, as more teams were able to begin stratifying, we were able to reflect that in new visualizations. And so it was really nice to have that dynamic process with how we displayed the data back to the teams from their hard work submitting it to us. Yeah, so next slide. All right, so this was our primary outcome measure, that improving the timely treatment of severe hypertension. The part of the run chart here with the white background represents the data submitted by our participating hospitals throughout each month of the collaborative. And the part that's in gray is some additional baseline data just to kind of establish sort of where we were at the starting point. So in the gray, you see the first 3 years of QIP-NJ aggregated performance data across all hospitals. And that's Medicaid data, Medicaid specific data, whereas in the collaborative, teams were reporting on all episodes, not necessarily limiting it to just Medicaid patients. But you can see, looking at that QIP-NJ baseline data, as a cohort, the state hospitals were never performing above 64% statewide. And that's remained consistent when we look at the first few months of data that was submitted in the collaborative. But we saw improvement as we went along, and we were particularly very excited to see that in the last 5 months of the program, almost all of the data points were over 70%. So we were really thrilled to see that progress as we moved forward. So next slide. And I think there was quite a bit going into what we learned, what we saw in the effort to improve timely treatment. And I think a big one revolve measurement and reporting questions, which also translates into some clinical protocols. So having our clinical faculty like Deborah and Ron was essential. We leaned on them quite a bit, as well as navigating culture shifts and coming up with sustainable data collection practices. So ultimately, we saw a lot of questions despite the AIM bundle guidance and the link to its key source, which is the Society for Maternal Fetal Medicine's special statement on this measure, which we had open nearly every day. Handy. I highly recommend keeping it on hand if you're running a collaborative on this. But just understanding, like, when there's multiple episodes, when does one start and stop when you're designing your reports and tracking your performance? It's clearly listed what the first line medications are, but there still were a ton of questions around this related to maybe the medications that made the most sense for a given team, how long-acting medications might be integrated into this process. And so we just noticed a lot of questions around that. And then a lot of questions coming through around exceptions, which relates to this culture shift around denials and delays, which we know is a major cause of the type of delayed treatment for severe hypertension, right? This is why it's one of the most highly preventable maternal emergencies. So, things like teams seeing, explaining away a severe hypertensive reading because it was during a painful contraction. And that is not an exception. And so we found things like providing some coaching around escalation protocols, where you can empower especially nurses, to say, that was a severe hypertension reading. Why aren't we kicking off this protocol? And then sustainable data collection, as Dak mentioned, it's a very manual chart abstraction based measure. And so, only a handful of teams by the end of the collaborative had developed real, elegant advanced reporting capabilities that analysts could generate on a monthly basis. So just recognizing that there is this manual element and start thinking through, does it become quarterly? Is it even smaller sampling? How do you keep this going when the collaborative focus wanes when it ends? And we saw, in addition to the escalation protocols, we saw teams, these are core things from the AIM bundle, integrating staff education on the protocols, establishing first-line medication order sets and having those available across the unit, and performing drills were all things most of our teams implemented. And in general, we also found that most practice changes took less than 6 months to test and implement. This is reported by our teams. And I think it's nice to share that, because if you're thinking about taking this on in your organization, at your hospital, it's not like this is going to take years to be able to achieve some tangible changes. The changes were able to be adopted relatively quickly. And in general, we had very high levels of participant satisfaction with the program, and with recognizing that the collaborative itself helped accelerate improvements in our core outcome. But the participant reported outcome that I think I'm most excited about is that 84% of our respondents indicated that participation in the collaborative increased their joy in work, despite dedicating more time and perhaps taking on more duties in order to be able to participate. It increased that joy in work, and that's huge. So I'll pass it to Christina to talk about the other measure we're going to highlight.
Thanks, Emma. So on the next slide, what you will see is actually, as I was mentioning a few moments ago, one of the measures that was brand new for every single system, every single hospital that joined us on this journey. And that was taking a specific focus on the timeliness of triage and measuring the percentage of folks who presented in pregnancy or postpartum who had that first blood pressure within 10 minutes of presentation at the facility. And what we saw was we went from baseline that, prior to measuring would have been 0 because nobody was actually tracking it. Using those first 3 data points and then comparing the rest of them, what we can see is a shift in that performance that was happening over time. When we're getting, in the latter stages there, getting upwards to 31% in that final data point. And if you go to the next slide, one of the things that I think was really exciting about this, first, as I said earlier, this was something we knew that every single hospital could focus on, regardless of how many births they had in a year. And that was particularly important because the participants ran the gamut from those that had, many, many births on a monthly basis to those that only had a few, yet this was still something that they believed to be important to them. So how do we give them opportunities to focus on something that they'll see more often and can see progress in as they focus changes there? So because it was new, one of the challenges was getting a tracking system in. And so just like the treatment metric that Emma was just talking about, we knew that systems were going to have to look at this manually initially, and they did. And because so much of this presentation was happening in the ED, we also knew that for a lot of teams, what they told us was that they had to establish some connections and lines of communication and come to common understandings with their colleagues in the ED around what were the standards that we were striving for and what were some of the processes that could be in place. And so one example, was a team you can see there that set up a whole manual data collection process. This team actually had an incident in the past, which made this timeliness of triage a particular focus point for them. And they came up with a whole process around how this data would be collected. I think the porters were involved in that process, the steps that were involved to be able to have someone get that blood pressure taken and get them up to the OB unit as soon as possible. And then across the board for the teams, over time, we saw more and more teams focused here as they became, they saw what their colleagues were doing. They saw, this is something that is important. This is something that we can have movement on. And so some of the successes were around using alerts, making sure there was signage that if folks came in who were pregnant or postpartum, that they knew that they should come to this front of the line. They should tell the person in triage that they were pregnant or postpartum, so that first blood pressure could be taken. And then really just ensuring that protocols and policies were aligned between OB and ED, to make sure that that blood pressure was taken. One of the interesting things also, I guess, in OB was looking at processes around, getting when patients present, making sure that blood pressure is taken right away and not after they've been roomed, after they've gotten undressed. And there was some interesting conversations that teams would have around, how do we make sure we have people feel welcomed and comfortable while still ensuring that we get that blood pressure within that 10-minute time frame, so that we can be alerted if there are any issues, while still making them feel like, that they're not being rushed along in the process. And so some really great progress there. And I'll hand it back over to Emma to wrap up in the last few slides.
Yeah, and so the work, where does the work continue? Where did we leave things? And I think clinically, one of our measures was around remote blood pressure monitoring and getting cuffs in hand prior to discharge. And that was that's one where I think the challenge is ongoing, despite widespread coverage of being able to provide pregnant and postpartum women with a blood pressure cuff, including all of the managed Medicaid plans. There were these other structural barriers that prevented teams from getting the cuffs in hand for discharge, like, oh, it's covered, but you have to go to a specialty pharmacy to get it. Oh, it's covered, but you have to order it in the mail. Or even just maybe the type of cuff that's covered didn't align across all plans with the processes and clinical support for their remote blood pressure monitoring program. And so that was something that having the state sponsoring the program, we were able to elevate and highlight, at the state level, and just try to see, as the work continues, the hope is there something that can be done to overcome these structural barriers, because these are covered. And so a lot of teams did find that charitable funding was what they were turning to kind of get an inventory on hand to get their programs off the ground. But obviously that's, that's fine. And that's definitely something to consider, but it would be great, since the materials are covered, isn't there other ways we could solve this problem? The next, if you advance again, Deborah, I think just a reminder always about to center equity in your quality improvement work. We know that to achieve equity, the investment in your effort and attention doesn't necessarily mean isn't going to be equal. You might do a quality improvement project without an equity focus, and you might improve your overall outcomes, but the disparities that have been persistent will still exist unless you really try to target that as a central focus. And we are excited to be able to do that again. If you advance one more time, we have the opportunity to work in New Jersey again. This is actually will be our third Breakthrough Series Learning Collaborative with the New Jersey hospitals. And in this one, we will be focusing on social determinants of health. And we're really excited to get that going this year. And last but not least, Dak.
Yeah, that pretty much wraps us up. Thank you so much for listening. I know we'd like to leave a few minutes for questions, but if you'd like to connect with us, here's our full team. And with our email and our LinkedIn, you can send one of us an email if you'd like to access our MLC compendium and course materials. If you're interested in reading up more on our collaborative, or maybe you'd like to reuse some of our materials within your own teams, please let us know. Send us an email. We also have this awesome celebration video, which was just dropped in the chat, where some of our hospital teams shared what they were most proud of from their MLC work. We also have this cool and true technological advancement, this cool QR code if you want to scan that to access it, but it's also in the chat as well. But that's all, folks. Really appreciate it, and thank you so much. So I actually think we can stay on this slide as we go into questions, just in case people want to write anything down. So.
Sounds great, Dak. And thank you, Emma and Christina. It was really such a great team to work with. I loved working with all of them, and Grace and Grace. So and Ron. So well, there is a question in our chat already, and I'm just going to let you decide who wants to answer this. But it says, was the New Jersey Medicaid Agency involved in this collaborative? And if yes, how?
Yeah, I can take that. So the program, the New Jersey Department of Health Office of Healthcare Financing engaged our team from Public Consulting Group to basically design and help implement the Pay for Performance program, QUIP NJ. And I think what was great with the partnership we have, that New Jersey was willing to invest in not just operating this Pay for Performance program, but also putting the effort into running this collaborative as a supportive element. So the Department of Health was sponsoring the collaborative. And in New Jersey, the Department of Health and the Department of Human Services are separate departments, but we collaborated quite a bit with DHS, especially in the collaborative, trying to understand coverage services, trying to understand ways that state-based resources that could help teams overcome challenges. So they're definitely, in terms of their program sponsors, advisors throughout the process, and obviously the decision makers to invest in this effort, which is huge.
Yeah, and then there was a comment. Well, I will say that I think it really did help having that state agency component like you were just talking about, and then also the First Lady's office being really engaged and interested in helping encourage participation and wanting to know how things were going. And there is a comment here from Kelly Wilson, and so she will probably want to reach out to you later, but she says they're just getting started, and this will be their first AIM bundle, will be hypertension in Idaho, in the state of Idaho, which, by the way, Kelly, I have family that live there. So yeah, so I'm glad to hear that. So anyway, seeing how to start and may need to connect for more help. So that was really helpful to her. So and I really do think having the equity focus from the very beginning was such an important component. And I need to also underscore how amazing DAC's ability to create these online data collection tools so that the teams could actually have their own charts. They could then print them out, share them with others. Is very impressive how he was able to make all of those real time for everyone. Marjorie, down in Florida. Hi, Marjorie. You said, can you share details on the number of charts abstracted each month by hospital and population included? And that's a complicated question. And
I know. I'm sorry. I'm just
Yeah.
wondering, because it's a manual process, do they like submit 20 charts a month? And who do you include in that? Is it any woman that's beyond 20 weeks, less than 7 days postpartum, even if they come in through the ED and go home? How does that work?
Yeah, I'll let Dak answer it because it did vary per measure a little bit. Like there was some unique challenges depending on which measure you're talking about. But yes, those are the important questions. Like, how do you actually do that? I guess, Dak, that would be you that would respond to that.
I can definitely I honestly think this question, we could talk about this in a whole nother meeting and just talk about extraction. But just at a high level, first we met teams with whatever data that they could share with us and abstract. That's where we started, right? So if it was one chart or if it was 20 charts, then that's great, right? But we've typically focused on our population was all of the emergency departments and the Medicaid population. But it's so much. There's so much that went into that process. Each different team that I'm like, I feel like I should connect with you offline just to.
Yeah, I appreciate it because we're getting ready to start this in Florida, and I really see the ER component. I know it'd be a huge challenge for OB departments, but I see the huge value of that vital sign check and the treatment, that piece. So I was so excited to see a little bit more. So we can touch base offline. Thank you.
Yeah, and just to add, I think it builds, right? Because there's We had teams that like from start to finish were sampling 10 charts a month, and by charts, I mean 10 episodes reported on. We had other teams that generated elegant reports who began not just tracking their performance on the first episode of an admission, but every episode, which of course is like the dream. That's what you want to see how well you're doing. For timely triage, mostly like I think a lot of teams began with like, we're going to test this process out on the day shift only and do 1 day of data a week. And, so it was like, but that would build over time. So I think you just have, like Dak has said, you have to meet teams where they're at and hope that you can help them build momentum, especially when they start to see motivation as a result of putting the data back to their teams.
And I will say, Marjorie, that this team is very easy to reach out to. They are serious about being willing to share what they've learned, and more conversations in that regard. And in the interest of time, I know we're right at 2 o'clock. I will say that one of the main things is active implementation support with coaching is really critical to success, and that was highlighted. And also just this comment, Khadija Chambers talks about like the inequities around blood pressures, access to blood pressure monitoring cuffs, and that's definitely an issue for the entire country. And I will say that it's not only gives having blood pressure machines, it's the staff that helps support women and helps them interpret that. So there's a lot more work we need to do on both on access to postpartum blood pressure monitoring. So thank you to our panel, and thank you to all of you for coming. We had a wonderful turnout, and look forward to sharing this nationally with all of you, and you can share it with your other colleagues. And once again, thank you for being here with us today, and we just appreciate all the work everyone's doing in the country to help save lives and eliminate disparities and ensure inequities are also in that we give equitable care. All right, thank you and have a great day. Bye.